having white blood cells that are attacking something, either the thyroid itself or tissue within the thyroid, and it's inflamed, enlarged, and boggier, and it has more vascularity a lot of times. So when I put color on there, it's more pulsatile or colorful.
Welcome back to another episode of the Peak Performance Life podcast. Today, I am very excited to have someone who has come very, very highly recommended, and it's a very hot topic right now. We have Dr. Ilan Kedan. He is a distinguished cardiologist with a career marked by an unwavering commitment to patient care, academic excellence, and technological innovation. We're going to talk about some of the new technologies that he's been using in his cardiolucent practice. He embarked on his journey in medicine at Tulane University School of Medicine, where he honed his skills in cardiovascular health and patient-centered care. And then his journey led him to Cedars-Sinai Medical Group, where he cared for over 10,000 patients, fostering a culture of excellence and growth. During this time, he became a leader in the adoption of handheld ultrasonic cardiology technology, performing over 40,000 point-of-care ultrasound exams. That's one of the main things we're going to be discussing today. This is pretty incredible. I have not heard many people talking about using these handheld ultrasonic cardiology technology that Dr. Ilan is using in his practice with his patients to really get a better idea of what's going on, with the heart and in the body. So, Dr. Kedan, thank you so much for joining us here today.
Thanks, Talord. This is a great opportunity, and I'm very grateful for the time and the interest, and just the chance to spend some time talking about what's really important to me professionally, handheld ultrasound. And we can talk about many aspects of it, and how valuable I feel like it is in the daily use of patient care and in daily use. So
amazing.
Thanks.
Yeah, you've come very, very highly recommended from one of the smartest people I know, who has used you and as his doctor, and he had some heart issues, whatever, and he started working with you, and he's been raving about you. And by the way, he's already kicked himself into shape, looking better than he ever has, feeling better than he ever has. So yeah, and when he was telling me about the things that you're doing, I was just blown away. So really looking forward to getting into it. Let's first start with a little bit of your background. I know you've been basically a cardiologist for almost 20 years or so now. First kind of in the, with Cedars-Sinai and those organizations. Can you tell us a little bit about your background and maybe a little bit about why you decided to go out on your own and do the things you're doing today?
For sure. And thanks again. So just going back to how it all started, I got my college degree in New York. I went to Cornell for college, and then I got a master's in public health at Columbia before going to Tulane, as you mentioned, for medical school, which was an amazing experience in New Orleans, which happens to be my city of origin where I was born. Most of my growing up was in Central Florida, Tampa Bay area, Clearwater, Florida, before going to college. And when I was in medical school, being in New Orleans and being at Tulane, we had an opportunity to really kind of get a lot of clinical hands-on experience. And that was part of, I guess, the central teaching aspect of the clinical side of the philosophy of how they taught medical students at that time at Tulane. And that really, I really internalized that. And I felt like, getting in there and doing the stuff, seeing the patients, rolling up your sleeves, it's one thing to look at the numbers. It's another, how do you acquire those numbers? How do you check a pulse? How do you check a blood pressure? How do you obtain blood from a patient? And every other kind of, procedure that we were allowed to participate in, I wanted to be part of that. And when I went to residency, which was at WashU in St. Louis, I kind of carried that with me, and I was really excited. And at that time, I started seeing the nephrology fellows. So those are the kidney specialists in training at Washington University, using this cart, which had a tiny little ultrasound screen, and they were identifying where all the vessels were, and they were placing dialysis catheters with ultrasound. And I was captivated by that because, when you're a resident on the floor, you're essentially going by anatomic landmarks. You're feeling where your pulses are, and you're moving laterally or to the right or to the left where the vein is going to be. And then you're kind of just sticking this like 6-inch needle that's like 3 millimeters in diameter just in there, and hoping you get something that's less bright red so that you didn't get into the artery. And when I saw these guys, placing perfectly, like systematically, cleanly, precisely, repeatedly, over and over again, the catheters in the veins, I just said to myself, that is something I really want to learn how to do. And there were limited opportunities. There was only one of those carts. It was really confined to the dialysis center, where the nephrology fellows were the ones who knew how to use it. And over time, the technology became more portable, more abundant, and less expensive. And in bigger hospital settings, there became more and more of them. So that is something I kind of kept my eye on. And when I went and did my cardiology fellowship at Georgetown Washington Hospital Center in Washington, D.C., I was grateful enough. I'm very grateful. I was fortunate enough to be able to be in a program where it was very much emphasized the hands-on acquisition of images. So a big part of what cardiology is, and the skill set that specializes in cardiology, is interpretation of ultrasound images of the heart. And that's called echocardiography. So as part of our training, when we were on call, we would have ultrasound. We would be required to do ultrasounds overnight, since the sonographers or the echo technicians were not working typically overnight, and the fellows were the people who would be acquiring those images. There was no portable handheld or small device. We had something about the size of like a riding mower, a little bit smaller, refrigerator size, 300 pounds, with wheels. And we would have to wheel it to wherever the patient's room was, either the intensive care unit or the floor or the emergency department, and then acquire those images. And then the next morning, we would have to show our work to the director of the echocardiography lab, Steve Goldstein. He's now retired, amazing guy. And he kind of held us to the flame and pushed us to get better at acquiring those images. But what I learned from that, obviously, how to acquire those images, but also the power of what that image, when you're with the patient at the time, could do to help you with caring for the patient. Mm-hmm. And, fast forward a few years after that, I left, and, I completed my training and started my my career at Cedars-Sinai Medical Group. And during that time, I was constantly following where the technology was going and seeking when and staying in touch with the large vendors and companies to see when and if they would have a portable pocket size or hand carried device. And sure enough, at the end of 2010, beginning of 2011, there was a commercially available handheld ultrasound. And it was essentially the size of a large iPhone. It was a flip phone, had a flip phone make, and it had a connected probe with a cable. And that was like my gateway. I was able to kind of secure funding to get one of those. It was, the pricing then is not too much different than the pricing now. And that was, 13, 14 years ago. Amazingly, the price has not changed, but the ability and the technology and the capacity has grown massively, immensely. So from that moment on, I scanned every patient I saw, and I was a salaried physician in a large multi-specialty practice group with managed care contracts and large volumes, hospital in outpatient. And I got a lot of experience. So, and during that time, it was intentional learning and presentations. And, it struck me as just a source of opportunity to try to get better every day, and something I could get better at every day. I'm not a golfer. People talk about that with their golf swing. They can work on their swing. People who love golf can swing the golf club 1,000 times and try to get better every single time they swing the club. I feel like that's like my golf.
Nice.
I thought about it. I think about it. I read about it. And during that time, I was just scanning every patient, acquiring the images, videotaping the images at the time. There were analog images in these old flip phone type of ultrasound devices. So I'd have to figure out a way to record those images while I'm capturing the images and acquiring the images. And so I'd be taking pictures of pictures or videos of pictures and then transmitting them, once we could text message little video clips to surgeons and wherever. It's always de-identified data, of course, and HIPAA compliant. And during that time, and I can stop at any time if you have questions, because this is a long story, and it's really fun for me to talk about and think about and kind of relive some of those steps. But during that time, one of the main acquisition positions for the probe is you kind of angle the probe in between the second and third rib along the sternum in the middle, and then point the probe directly where the heart would be. That's called the parasternal long axis. It's along the sternum, and you're taking a picture of the long axis of the heart, so it looks like a cylinder. And one of the secondary views was the subcostal image. So underneath the rib cage, there's soft tissue. That's where your stomach is, like where your liver is. It's like where your solar plexus is. If you have ever been punched there as a kid or anything like that, unpleasant. But that's like the window to the heart. If you angle up underneath the ribs, you can see the heart beating beautifully. And so that's one of the secondary images. And in that position, you can measure various different anatomic structures. And in my kind of life of curiosity and opportunity, I started noticing that if I angled the probe, and looked literally 2 inches to the right, the patient's right, there's all these other things there. Oh my gosh, that's not cardiology, but guess what's there? There's a liver, there's a gallbladder, there's a kidney, there's all the stuff around there. Sometimes I can even see the head of the pancreas. I can see all the vessels off the abdominal aorta. So the abdominal aorta comes off the heart as the main, that's the main tube or artery that comes off of the heart. And it's like a candy cane. It comes up and down and then branches to the legs. But there's tiny little branches off of that. And I can learn all those different branches and where they go. I can see, and if I really expand my view and line of focus, I can look at both kidneys. I can look at the spleen. I can look at the bladder. I can look at the prostate without doing anything other than moving the probe no more than 5 inches from where I was looking at the heart.
Wow. So this seems like it can be used for, obviously you mentioned it was already being used kind of with kidney and for dialysis and things like that. But this seems like this could be used for a lot of different things, but yet I haven't heard of too many people talking about using it. It's pretty incredible.
Well, keep in mind, for me, it's second nature, and I've been doing this for a really long time. And, the repetitions, over 40,000 repetitions with intention to improve with each. So it's not like it's internalized, but from my standpoint, it's better data for making impactful clinical decisions when you're with the patient. So
Yeah, and let me ask you about that, right?
Yeah.
Because I think let's back up and the listeners right now, right? A lot of people who are thinking about cardiovascular issues, they might be thinking of cholesterol or high blood pressure, or are these cholesterol numbers really, do they even mean anything? We've had multiple people that come on this podcast that say actually cholesterol is good for you and it's a building block for hormones. And
Hmm.
people have said, he used to work in a cancer clinic and everyone in the cancer clinic basically had low cholesterol. And there's like all these different things you hear. Cholesterol has got to be one of the most confusing, kind of up in the air topics, at least for me. I've heard so many different viewpoints. You hear some doctors say, yes, you must put anyone who has high cholesterol on statins. Other people are like, I would never prescribe statins to my patients. And, so there's so many different things here. Now, let's talk about the difference about what a traditional cardiologist would do, right? So someone has high cholesterol, high blood pressure, they go to a cardiologist. This cardiologist, I assume probably more than 90% of them, or maybe more than that, are not using the ultrasound that you're doing, right? So how
Right.
are they going about determining what the issue is versus how you're going? What are you looking for in these ultrasounds, like that the traditional doctor wouldn't be able to know just with a blood test result?
Yeah. So it's a good question, and actually, that it's a deep question.
Mm,
You mentioned, decision making, and with respect to advising and management of cholesterol, which is another way of saying like how we might manage cardiovascular disease risk. Um, and that's a very complicated conversation, but I love that conversation because it's more than just a cookie cutter approach. For each person, there's each set of genetic variation and personal goals and what's attainable from a personal, professional, lifestyle standpoint versus like what's practicable, meaning like how can this be executed in a way that's not going to take longer than you're going to see the benefit. So the time horizon for improvement or physiologic change, which is what we're trying to affect with treatment or intervention of any kind, where the physiology is perturbed. We're seeing that with abnormal lab values, abnormal blood pressure, abnormal body fat percentage, um, perturbations in how well you can move your body, how flexible you are, how quickly your brain works, and how you can impact that to a preferred state or a improved state from the current. So therein is the dialogue.
mm,
Everyone is entitled to make a decision. And, I'm in the business of not telling people what to do, but sharing information. And
mm,
what's, I think, very impactful with the handheld ultrasound and how I can really leverage that technology is we can share this moment together. I'm looking at your heart. You're seeing your heart when I'm seeing your heart.
mm,
And I'm showing you all the parts, and I'm able to share if there's any kind of valvular problem or problem with the valve or problem with how well the heart is squeezing, how thick the wall muscles are. I can measure all those things. I can share all those things. I can show you also how, in some cases, how stiff the heart is, which can be associated with like chronic physiologic changes that may or may not be actionable or changeable in a reasonable timeline. And then
mm.
keeping all that in mind, I can also share with you what your liver looks like. Does your liver look echo dense? Does that, and is that suggestive that you may have dysmetabolic um, syndrome or a syndrome of impaired metabolism of glucose, cholesterol, triglycerides, fats, and you're depositing fat in your liver? Then that's actionable. I can look at the kidney. I can look at how thick or thin the cortical layer, or which is the action part of the kidney, is, and I can see that this long term hypertension or long term high blood pressure that you've had, or this untreated sleep apnea associated with your extra weight that you're carrying has led to end organ, meaning the visible image of the kidney or whatever the organ of interest is, as an abnormality. There's a change there. That's physiology, that's inaction that has resulted in change. And some of that is very impactful. And when we get to the vessels, I can look at the vessels. I can see the abdominal aorta. I can look at the femoral artery. Those are the two of the earliest places you'll see hardening or calcification or plaque. We hear about plaque that turns to bone, that's actually like ossifies or becomes stiff and hard and develops calcium. And I can see that in the carotid arteries as well. And that is something you can't unsee when you see it. If you think, I'm going to eat and lifestyle my way to a normal everything, okay, I'm with you. Let's go on that journey together. I'm here for that. But at the same time, like, that might take you some time. It took a while for you to get to where you're at. All these chronic processes, which are processes of aging, don't take place in 6 months or 1 year or 5 years even. These are diseases or processes of decades. And as such, what do we have from a medical standpoint? Well, we don't have too many hammers for that nail. And one of the hammers we have is lowering cholesterol. And how you get to that lowering cholesterol may be up for debate as far as like what you believe in or what you feel comfortable with. I'm here for all that and that whole conversation. I also know, we're limited. So we're limited in time and resources and capacity. So the simpler, the better sometimes. Yeah.
So there could be a situation, for example, where someone, and again, there's other things too, right? Because it's not just as simple as, oh, your total cholesterol is high or whatever, right? It's like there's, some people have low triglycerides and high HDL, which, I hear is a good thing, but then there's even different markers. But furthermore, you're looking with the ultrasound, so you might see someone who maybe they have slightly elevated cholesterol, but their triglycerides are good, their HDL is good, and when you do the ultrasound, maybe they're clean and they're good, right? In some ways, and in which case maybe they don't need to go on statins, right? Is that kind of like an example of how you might?
That would be an excellent example. Again, it's not. Cholesterol and cardiovascular metabolism aren't the only things that we're managing. That's more a preventive or ideally preventive, sometimes secondary prevention. Sometimes people have an event or they are identified as having disease. And then now we're trying to prevent the second or subsequent further events that may come thereafter. But there's other things that we can identify and actually treat and manage with ultrasound. But actually, to your first question, I think I may have missed the actual, we went past the actual question, which was how do other people manage this and manage cholesterol and manage cardiovascular disease? Well, there are very kind of clear, defined set of guidelines that are used. And when you're busy in life and as a physician, as a patient, and you get really a sliver of time to kind of operate in a decision-making capacity and advisorial capacity for a patient, you might be limited to fall back on the same pathway, which is, these are the guidelines. This is what I recommend. Your LDL is this. This is the recommended approach. Bop, 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 bop. If you have symptoms, call me. Otherwise, you're good. And that's it. Maybe try this diet. This is the one that's been endorsed by the American College of Cardiology. And that's the one we can recommend because there's no data for anything else, and and we're locked. And it's easier, and honestly, there's benefit to that because what else can you say if you really have 3 minutes with somebody?
Right.
What are your options? And I'm not I'm not trying to disparage that. I mean, that's the reality of like what my life was like as well, up until I started my own company in cardiology earlier this year. So it's not an easy path. So that's standard. That's the typical.
Yeah. Yeah. So standard is you see a blood test, numbers are here. The book tells you if the numbers are this, you prescribe this kind of a thing unfortunately, they don't have, would be amazing if actually people see, I imagine right now you're actually probably most of the people you're seeing, correct me if I'm wrong, but they're probably had some sort of issue and then they're going to you and then you're scanning them. In an ideal world, we should all get scanned ahead of time and have a more preventative approach, right? Versus a reactive approach, I would imagine. That would be.
Yeah. I mean, in an ideal world, right, we're working when the clock starts and stopping work at when the clock stops, and we're taking a healthy lunch and taking a walk after our lunch and sleeping 8 hours and not involved in conflict and not depriving ourselves of nutrients. But life happens, and we can't control that. So that's kind of gets back to the point, like in many cases or most cases, we can't just lifestyle ourselves out of where we're at when we get to the point where they show up and see a cardiologist, or when a patient comes and sees a cardiologist. Not to say that that's nihilistic or cynical in any way, like, oh, just give them pills and just like move on and next. But there's some value in bridging someone from perturbed physiology to normal physiology with medications that can help stabilize the physiology. Having high blood pressure of 180 while you're getting your lifestyle under control, and that which may take 3 years, isn't healthful. And it increases your risk of stroke and kidney disease and eye disease and various other terrible things or undesired things. So, there's a role and there's room for all of it. And what it does take is time.
Yeah.
And taking the time is really the luxury that isn't necessarily afforded in a lot of healthcare systems, unfortunately. There's more work than there is time to do the work.
Right. And that's where your kind of your new practice, where you're able to go see patients, you're even able to go see them, bring your ultrasound device with you and kind of see everything that's going on and work. And I think too, for people, obviously it's probably not, for people who maybe have the means and maybe they're on statins, but they're like, I don't want to be on statins. Do I really need to be on statins? I have some questions here. I think that would be, because I think, again, there's so much different information about statins. And a lot of what I've heard, we have a lot of holistic people on here, and they're like, down with statins. I'll never take a statin. And honestly, I've kind of adopted that mindset myself, if I'm being honest, right? But what the hell do I know? I'm not a cardiologist for 20 years. Yeah, you've done 40,000 ultrasounds on people, right? So I'm just kind of going based on, what I'm hearing the majority of the people that I kind of think kind of resonate with what they're saying. So yeah, that could be an interesting thing where people could say, hey, if I'm afraid of maybe potential side effects of statins, before I take them, or if I want to see if it's okay to get off, let's do an ultrasound and see where we're really at here and how bad the damage is and if I really need this.
I mean, that's a very valuable tool to inform someone of what's actually happening. And I can say that, like, when people take action, they can see differences. What's lost, or someone might say has been lost in modern healthcare, is time with face-to-face time with a physician and a patient. And what that would include is an actual examination. And I'm not talking about like you put the stethoscope around your neck and then, lean forward and what does it sound like? Or mashing on someone's abdomen and saying, does that hurt? I mean, that's, don't get me wrong, it's better than nothing, but like, we're not talking about an actual examination. And when you have a tool like ultrasound that will actually give you what's behind the drywall, essentially what you can see inside, I think that if you know what you're looking at and you're practiced at it, which, honestly, nothing is a skill that can't be acquired with practice. It's dexterity, but it's image acquisition. It's very similar. Like, I think about it as like a video game. I move the probe, I look at the screen. When I move my hand in one way, I get the image in a different way. So it's not like it's not a shooting game or anything like that, but it's a game to get the picture the way I want to get the picture, and then I acquire the images. And those images can be stored and shared and reviewed and compared over time. And that is very impactful when patients change their lifestyle and change their life or take medications. They can modify how the anatomy looks. And you're looking at anatomy in response to treatment changes, be it medications, lifestyle, diet, whichever, surgery, and you'll see anatomic changes that are maybe preserving or restoring a more physiologic or normal physiology.
Yeah. So like, I'm kind of curious. I bet a lot of people listening now are also wondering. So, okay, so let's say they come see you, you use this ultrasound on them. I know you mentioned kind of some of the things, and I've kind of heard these terms, right? Like calcified plaque, things like that. What's really bad? Like, if you're like, okay, I see that's really bad, versus like, yeah, what do you kind of like specifically, like, number one, like, all right, I'm really looking for this big thing, which I know is really bad, and, calcified plaque around the artery or whatever it is.
Good question. So in the context of like what is most predictive of an adverse event.
Yes.
So from a holistic standpoint, what's most predictive of an adverse event is how fit you are and what your oxygen consumption max would be, or VO2 max. So if you work backwards and you say, okay, an excellent VO2 max and an excellent exercise tolerance and a capacity to just like run all day or run up 10 stories of stairs without any kind of like huffing and puffing, carrying like 40 pounds of groceries is your like, ceiling, and barely getting out of a chair to go to walk to the bathroom is like, that's problematic. What can I look at anatomically that may be predictive of that like poor VO2 max? When people say they feel good, when people say that they don't have symptoms, that's a reported, experiential perspective. That's not necessarily documented, observable sort of like point of data that is reproducible per se, until you measure it. So what I'll look at is the heart. And if I see the heart as normal size, shape, contours, and structure and function, then okay, great. The heart is structurally looking normal. So all the parts are where they're supposed to be. The valves are opening and closing in an appropriate, like, physiologic way. And there's not like leaking. There's not like thickening or restriction of movement. Okay, that's really, really helpful. So I know that structurally there hasn't been damage to the heart, and functionally I see that the heart is actually moving. So those are two excellent starting points, and I look for that. Then one of the things I'll look for is, what are the pressures in the heart, and how can I measure the pressures in the heart? So when the pressures are elevated in the heart, I can assess that with ultrasound. And filling pressures being elevated in the heart translates to adverse physiology. So backup of pressure, into the lungs, into the liver, into the abdominal cavity, and into all soft tissue and interstitial or places in between the organs. So I can measure that by looking at various different things. And with Doppler, I can assess. Doppler is like a measure of velocity of flow across structures. I can measure that. And I can also measure the diameter, which is one of my favorite things, the diameter of the inferior vena cava. The inferior vena cava is the large vein that brings blood back to the heart from below the diaphragm. So underneath your lungs, the veins all the roads lead to Rome, and Rome is the right atrium. And that is a continuous column of blood that I can see and is represented in the inferior vena cava. And based on the size of that, the stiffness of that, and the elasticity of that, the diameter, I can roughly gauge what the right atrial pressure is, which is consistent with and has been scientifically demonstrated to be consistent with the central venous pressure, or the pressure in the entire body. So that's from the cardiovascular standpoint. And that can be modified with medication treatment, diet, lifestyle. All those are modifiable. So I'm assessing the anatomy and I'm assessing the physiology when I'm looking with the ultrasound. And that's super valuable and super important. And if I were to give medications, I can see changes in all of those things, which is incredible. And it's like very reinforcing for the patient and for, whoever's caring for the patient. So bad would be not moving heart, high filling pressures, valves that are messed up. Those would be, if you were to have a preference to label it, that would be bad. And good would be none of those things. Normal heart function, normal size, normal valve function, compressible, normal filling pressures.
That makes a lot of sense.
Yeah.
That makes a lot of sense. So I think you're based in Beverly Hills now, right?
That's right.
Yeah. And so let's say someone is on the East Coast and it's not practical for them to see you. Obviously, we're going to link to your website and give all your information here in just a little bit. But let's say someone's on the East Coast. They probably don't, it's not practical for them to come see you or something like that. Would you recommend that they look for a cardiologist that uses ultrasound specifically? And are there even many of those people out there?
There aren't many people who are out there who are experienced and like incorporating handheld ultrasound, especially as a cardiologist, in their day-to-day care of patients, unfortunately. When I started with the handheld ultrasound in 2011 or so, I thought, man, in 10 years, everyone's going to be using this all the time.
They should be.
And here we are. Nothing's really changed that much. I mean, it's definitely not as rare as before, but systematically looking at all the parts with an intention to kind of acquire information that could be actionable is rare. So someone who's enlightened, who you can connect with and have a dialogue with, ideal. Again, there's a scarcity of everything. So, someone who will listen is probably the number one criteria, and someone who's actually like kind of thoughtful and not dismissive. I'd say that those would be extremely valuable traits to be like seeking out someone who's a cardiologist in general. So
it's going to be tough to find someone who's actually using the ultrasound, which seems like such an important thing that really, after this conversation, I'm already convinced that every cardiologist should be using this. Maybe we can help spread the word here, man. Maybe you can start teaching some of these other physicians how to use this thing and make it more prevalent so people can get better treatment. Because again, going back to the whole thing, and I'm curious actually to get your opinion on this. So there's the whole, like with the cholesterol debate, right? So a lot of the holistic doctors are saying, well, it's not really cholesterol, it's the inflammation in the body. And typically when you're inflamed, you'll also have high cholesterol. So it's being mistaken as high cholesterol is a problem, but it's really high inflammation is the problem. And cholesterol is being labeled as the villain. And there's some sort, and then there's people who are, on keto or who are in great physical fitness, but they're lean mass hyper responders. I don't know if you saw the whole study that's been talking about recently about lean mass hyper responders who are super healthy, fit people, but their cholesterol is through the roof because they're on keto or whatever the case may be. But I guess in general on this question, do you, based on your knowledge and what you know, do you think it's more of an inflammation issue or more of a cholesterol issue? Where would you stand on that debate?
Yeah, so it's a interesting question. I mean, it is open for lots of deep thinking. I would say that inflammation in general is probably more problematic, and the challenge is how do you measure that, and what are you measuring? Are you measuring inflammation in the cell? Are you measuring inflammation on the vessel? Are you measuring inflammation in the joint or in the muscle? And inflammation can be episodic, or it can be consistently elevated with episodes of perturbation and worsening. Or if you get a cold or you have slam your toe in the door jam, you're going to have some inflammation. What is that doing? I mean, what are we measuring?
Right. I guess like HSCRP would be like the blood marker that's most commonly associated with inflammation. With your ultrasound, are you able to see would there be ever inflammation around the heart or things connected to the heart that you'd be able to see?
Definitely. So what I can see in rare cases, and I've definitely seen this, is thickening of the lining around the heart. Like it's called the pericardium. It's every organ in our body is wrapped in like a cellophane type of. It's not cellophane, obviously, but it's a layer of cells that is encapsulates each organ, and each of those are the boundary of the organ itself. And if there's inflammation around that, I can see that. I can see fluid collecting underneath that. I can see thickening or brightening of that line. It's essentially a line because we're looking at two dimensions with an ultrasound. We're looking at a flat screen with an ultrasound probe. I can see that. I can look at the thyroid and I can see that the thyroid looks inflamed, where there are white blood cells that are attacking it. You have a disease or condition called thyroiditis. It's super common. It can be associated with any number of bad luck things. And it looks characteristic like thyroiditis. And what is thyroiditis? It's white blood cells. The body itself is having white blood cells that are attacking something, either the thyroid itself or tissue within the thyroid, and it's inflamed, enlarged, and boggier, and it has more vascularity a lot of times. So when I put color on there, it's more pulsatile or colorful. I can see that. I can see that in other organs as well, less often, but it's definitely there. And that would be associated with an elevated C-reactive protein, more likely than not.
Yeah.
But like I mentioned, the high CRP is something that can be, it's a non-specific marker of inflammation.
That's true. Yeah.
So
yeah, very true.
Yeah.
And the ultrasound, the ultrasound is the way to go. Let me ask you this: are there any things? So let's say someone can't find a cardiologist with the ultrasound, which I'm convinced you need to find one now, right? So, what is there? Is there any are any of these other full body MRI scans or any of these other new kind of technologies that everyone's talking about recently? Are any of these full body scans or anything like that going to give you kind of similar information to what the ultrasound would?
Similar, yes, for sure. So if you were to do imaging of the body, whatever that may be, now those are, remember, it's a different context. So this is a static picture or a set of pictures that are either acquired by a technician or a machine, and then those images are interpreted at a separate time from when you're with the patient. So there's context that is removed. And, if there's masses or if there's plaque or there's disruptions of borders of vessels or around organs, you'll see a lot of that. What you won't see is changes with respiration and angling of the probe and positioning in the patient and size of where things are located and contextualizing like where the organs are in relation to the spine, in relation to each other when the patient's on their back or supine. So it's not bad data, it's excellent data. And it's not standard data that you would necessarily collect. And it's definitely not, it's more of a screening tool than a kind of data acquisition for construction or hypothesis testing, I should say. So when I'm examining a patient, I'm putting together a hypothesis based on their symptoms, how they're feeling, their review of systems, their laboratory data, their history that I'm able to kind of collect, review, and think through before I even see them. And then formulating a hypothesis that I can test with the ultrasound when I'm with the patient and share that with the patient.
Yeah. Well, look, I also really love, by the way, how you're really taking a holistic approach to this in terms of you're not just looking at the heart. You've mentioned the thyroid, you mentioned the kidney, you've mentioned the liver, right? Different things that all could be having, a downstream or upstream effect, however you would call it, to the heart. So it's I really like how you're doing that. I mean, from what I'm hearing here today, it's so different from what you hear a traditional cardiologist doing, again, just looking at a blood test, looking at the numbers, prescribing statin or whatever it is. So I'm really, really excited about this. And I just think, I guess if someone can't somehow make it to see you, then I guess some sort of full body scan or something like that would be the second best option, I would imagine. But yeah, I just wish more cardiologists were doing this. Maybe we can get some sort of directory of cardiologists that use ultrasounds going, and different people in different areas could access that. I do want to ask you, I know we're kind of running short on time here, just kind of general advice for the listeners. You mentioned things like VO2 max. You mentioned, kind of people who want to prevent this sort of issue. They don't want to, I mean, like me, my thing is like, I want to avoid taking any medication for as long as I possibly can, because I've just seen how when one person takes one medication, they might have a side effect. The next thing you know, they're on another medication, and it can spiral really quickly. What's kind of some general advice for the average person listening here that wants to make sure they always have as good of heart health as they can?
Yeah, it's a excellent question. And I think that thankfully there's a really simple answer. And I hate to say that it's like a one size fits all, but if you're going to measure and recommend any intervention, there's no medicine, surgery, any kind of lifestyle that's more impactful than being lean and fit. So how do you measure your fitness? Well, you get on a treadmill or you do a VO2 max if you want to be quantitative and measure, like that's my capacity at maximum, and you train to max out your VO2 or oxygen consumption capacity. So that's
is there any training that you do? Is there any training that you do or recommend for someone who's listening who says, "Oh yeah, I want to increase my VO2 max"? What's the best?
Well, that it has to be tailored to everybody. Unfortunately, there's not a one size fits all. Just like there's 300 different Olympic events, you can't train. I've
heard a lot about HIIT training, right? Like doing HIIT training where sometimes I'll hit that assault bike and just go all out as hard as I can for 30 seconds and then rest for a minute or two and do 4 or 5 rounds of that.
That's excellent. And if you can do it, that's great. But keep in mind, with intensity comes injury risk. And if you're injured, then you're doing zero exercise. So the balance is to find that like way you can maximize your intensity without injury. Injury is your nemesis.
And the HIIT training, I will tell you, man, the HIIT training, like when I do, that could be that could only take a total of less than 10 minutes, but I'll be more wiped out for the rest of the day doing 5 rounds of 30 seconds on the assault bike than I will be from doing a 90-minute, weightlifting, circuit. So it's pretty incredible. And actually sometimes I've shied away from doing the HIIT training because I'm like, I still want to be productive and not be drained, after today. So I think you're right there. Yeah. So it's got to kind of be within the person's capability of still, you don't want to have to do these things where then you just have to lay down on the couch the rest of the day because you're completely beat.
Right. So that's fit, but then lean. And how do you get to lean? Well, we can measure lean. So I can measure it, you can measure with your height weight ratio. So there's this body mass index ratio that's not necessarily representative of like how much body fat percent you have. You can measure your body fat percent. There's various different scales, which may or may not be relevant, but at least it's like some sort of bookmark which you can work towards. And the kind of, I guess, gold standard or optimal way of measuring your body fat percent would be to use a DEXA scan, which is using x-rays, very low level of x-rays to assess your body mass and body fat percent, and use that as a bookmark that you can train to lower or increase if you're low body fat, and increase your lean muscle as well. So those are the two interventions, if I were to say, like, better than any pill, better than any surgery, better than any other recommendation. Of course, you want to get fit. It's not like you went to the gym and you're good once. You got to do it every day, just like you brush your teeth every day and tie your shoes every day when you put your shoes on. So it has to be internalized for it to be most effective. This is my opinion, of course, but it has to be internalized as something that's part of your routine.
Right.
And having personal trainers or having a customized, personalized training program is probably the safest way, especially for people who are not experienced with, regular routine training. It's really easy to hurt yourself when you're over 40. Sorry to say, you go to the gym and you blow out your shoulder and like, now I can't lift up groceries anymore. I can't even pick up a
That's
pen.
bad. Yeah.
That's a problem.
I completely agree with you. I'm a huge advocate of people getting trainers, coaches, nutritionists, the whole deal. A cardiologist like you who use ultrasound. So, I mean, this is really amazing. I'm really, really excited about this conversation. I'm going to be telling a lot of people about this. I'll be referring people to you for sure. Hopefully many people listening right now. Let's tell everyone where they can find you, follow you, and potentially reach out if they're interested in getting a scan.
Oh, for sure. So my company's name is Cardiolucent, and I'm at cardiolucent.com. You can see me there. You can call my office. It's a very excellent phone number, 310-304-5555. Really easy. And I'm here to see patients and do work to help people clear the path to their better health, to find a way to help themselves get better at everything in their health with respect to their health, especially their cardiovascular health.
Amazing. Dr. Kedan, thank you so much. This has been really eye-opening, really amazing. I had not heard about this before. When my friend told me about this, I was really excited to get you on, really happy to share this with the listeners, and really, really think this is important, right? I think there's certainly, in my opinion, again, and in the opinion of many other people who have been on this podcast before, is that statins is possibly the most overprescribed drug. I think it is the most prescribed drug, right, of any drug. Is it overprescribed? Again, that's up for debate, right? But again, if people have a scan and then see, it could potentially, maybe they don't need it. Maybe they do need it. Maybe they need a stronger intervention. Whatever the case may be, I think you can't just see that based on cholesterol numbers. I think I just don't see how we're operating in a way where people are just looking at blood test numbers and looking at basic cholesterol numbers and prescribing medications especially other doctors who are not even advising any lifestyle interventions along with those prescriptions. So I'm just really excited about what you're doing and how you're sharing it and helping people. And you've helped a dear friend of mine tremendously already. So, thank you for that. And thank you for all that you do. And I hope we can, we'll have to have you back on again sometime soon. I think my friend actually mentioned too, he said, hey, I can hop on the podcast. I'd be open to it. And we can do one where I talk about all the things that I've learned and how he's helped me and all that kind of stuff. So we'll have to do this again sometimes, but this has been an absolute pleasure. Thank you so much.
Amazing. Thank you. This has been an amazing opportunity. It's been really fun getting to chat and talk about all the things that I like to do professionally.
Amazing. Thank you. Thanks for listening. If you enjoyed the episode, can you please leave us a rating or review and subscribe? I've realized that while we have actually increased our downloads a lot, we're actually getting a lot of downloads, which I'm really happy about. We actually have very few ratings. And I realized that I've never asked people really to rate much. So I'm asking you now if you could please rate and review and subscribe. And if you enjoyed the episode, please forward it along to anyone that you think will get value out of this. Also, if you haven't checked out our line of products at buypeakperformance.com, you get 20% off your first order. That's www.buypeakperformance.com. We have some incredible products, including our organic high-altitude coffee. If you don't know this, coffee is one of the most heavily sprayed with pesticides out of any crop. So it's really important that you drink organic coffee. We've gone above and beyond to source what we believe is the highest quality and healthiest organic coffee in the world. We're also famous for our organic green superfood powder. You can get 20% off of that as well at buypeakperformance.com. We also have an organic vegan and paleo plant protein. See, most of the vegan proteins out there are using brown rice protein, which is really not a good source of protein, and it's also a grain. And if you're paleo, you know that grains tend to cause inflammation in some cases for some people. And so we wanted to make one that was paleo friendly and vegan and organic. We made an amazing amino acid profile, so it's really one of the best plant proteins for muscle building. So you can check out Peak Performance Organic Plant Protein. You can find that on our website. Of course, all our products are on Amazon as well. So thanks again. And again, please, if you enjoyed the episode, please forward it along to someone who you feel can get value out of it. And please leave us a rating, review, and subscribe. Thank you.